Welcome everyone, and this is lecture 37. I'm Dr. Mohammad Tinawi. I'm a nephrologist in Northwest Indiana. This series of lecture is on fluids and electrolytes. It is based on my book, Manual of Fluid, Electrolyte, and Acid-Base Disorders, a pathophysiologic approach to common clinical problems. You can find the book on Amazon at the link below. Today we are still on chapter 5. This is the last lecture, and we are going to do case studies on hypomagnesemia and hypermagnesemia. Let's get started. Case number 1, severe hypomagnesemia. 52-year-old man presents with nausea, dizziness, weakness, and muscle cramps. He has a history of hypertension and GERD. His medications include amlodipine for high blood pressure, pantoprazole for GERD. The patient has been taking both medications for 7 years. A chemistry panel was obtained and was significant for low potassium, 3.3. Magnesium was very low, 1 milligram per deciliter. Calcium, 7.7. Albumin, 4.1. What is the etiology of his symptoms? So this patient has hypomagnesemia due to chronic use of pantoprazole. Like we said, PPIs, proton pump inhibitors, lead to GI magnesium loss due to decreased absorption. Why? They down-regulate the TRPM6 channels. Therefore, hypomagnesemia in this case led to hypokalemia and also hypocalcemia. What can you do? Well, he has GERD. You cannot stop the pantoprazole, so you supplement magnesium, usually with the magnesium oxide. Next case, preeclampsia. 35-year-old woman, gravida 1, para 0, was diagnosed with severe preeclampsia. She was noted to have hyperreflexia on exam. So she's immediately started on magnesium sulfate IV for seizure prophylaxis. She was given a loading dose of 6 grams IV over 30 minutes, followed by continuous infusion of 3 grams per hour. After 5 hours, she became lethargic. She was unable to urinate. Her deep tendon reflexes became absent. What should be done next? This patient is exhibiting signs of magnesium toxicity, the absence of deep tendon reflexes. So what do? You stop magnesium sulfate immediately. You check serum magnesium, and the patient was started on 0.9 normal saline at 125 ml an hour. Also, we give magnesium, in case of magnesium toxicity, we give 1 gram of calcium gluconate intravenously over 5 minutes, like you would do with hyperkalemia when you have EKG changes. Here, the EKG was unremarkable, but due to neuromuscular toxicity, we gave calcium gluconate. Serum magnesium came back at 7.4, so we don't wait to do these measures. We don't wait for serum magnesium to come back. So we stop the magnesium and we give calcium gluconate. Now, we have to remember that magnesium sulfate is the drug of choice for seizure prophylaxis in preeclampsia, and we can achieve that with lower doses of magnesium sulfate. We don't need to drive the level up to 7.4. Case number 3, lethargy in a hemodialysis patient. Here we have a 56-year-old man with a known history of ESRD. He was brought to the emergency department due to lethargy, confusion, and blurred vision. He's been on dialysis for 5 years. His family reported that he uses a lot of over-the-counter medications due to severe constipation. Neuromuscular exam showed absent deep tendon reflexes. How would you manage this patient? So when we hear the word laxative and chronic kidney disease and absent reflexes, we need to check serum magnesium. This patient was questioned and was found to be taking a large amount of milk of magnesia. Now, the active ingredient of milk of magnesia is magnesium hydroxide. So, due to his ESRD, he developed magnesium toxicity. His level was a whopping 8.3 milligram per deciliter, but no EKG changes. So what did we do? Again, 1 gram of calcium gluconate, 1 liter of 0.9 saline, and immediate dialysis. Here we have a dialysis access that is readily available. So you put the patient on dialysis for 4 hours, and after that you get the magnesium down by half, 4.8. After that you just observe him. So he was instructed to avoid magnesium-containing laxatives and also magnesium-containing antacids, and he was told to consult with his nephrologist prior to starting any new medication, whether prescription or over the counter. Case number 4, hypomagnesemia and congestive heart failure. 69-year-old man with chronic systolic CHF, ejection fraction only 20%, magnesium 1.4. He takes lisinopril 40, furosemide 40 BID, and carvedilol 25 BID. Blood pressure control is optimal. Serum creatinine stable at 0.8. Serum potassium is a little bit low, 3.4. How would we manage his hypokalemia and hypomagnesemia? I presented a similar case when we talked about hypokalemia. We're not going to discontinue furosemide because that will lead to fluid overload. If we supplement orally magnesium and potassium, it's going to solve the problem, but it's a lot of pills. Since we have chronic systolic CHF with low ejection fraction, ideally we should start spironolactone. This will help with the hypokalemia, with the hypomagnesemia, and with mortality. So what more would you ask for? Spironolactone decreases morbidity and mortality in patients with severe systolic congestive heart failure. Case number 5, Magnesium and Patiromer. Here we have a 60-year-old woman with a history of stage 4 chronic kidney disease secondary to diabetic nephropathy. She presents with nausea, dizziness, muscle cramps, and fasciculations. Medications include glimepiride 4 mg daily, atorvastatin 40 mg daily, lisinopril 40 mg daily, furosemide 40 mg daily, and Patiromer, which is a new potassium binder. We did 2 lectures actually on potassium binders, 8.4 grams daily. Now, Patiromer was started due to hyperkalemia from the lisinopril. So what do we do here? Why is the patient having these vague symptoms? So when we have vague symptoms like this, we're going to check electrolytes, and she is on Patiromer. Patiromer is not only a potassium binder, but is a magnesium binder, so we have to check magnesium. So a chemistry panel was ordered and revealed creatinine of 3.1, potassium of 4.9, so she's no longer hyperkalemic, but she is hypomagnesemic. So her symptoms are due to hypomagnesemia. So Patiromer binds both potassium and magnesium. So we're not going to stop Patiromer because it's allowing us to continue lisinopril, which is very helpful to this patient. Furosemide also, her intake of furosemide aggravated the hypomagnesemia. So we have 2 factors, furosemide and Patiromer. So in this case, Patiromer was continued and the patient was supplemented with magnesium oxide 400 mg PO TID, and that solved the problem. Case number 6, hypomagnesemia in a child. Okay, this case is for the pediatrician or the pediatric nephrologist, or for the one with a lot of intellectual curiosity. Okay, a 7-year-old girl presents for evaluation, this is a true case, a 7-year-old girl presents for evaluation of chronic kidney disease. She is complaining of muscle cramps and fasciculations, polyuria, and polydipsia. Her past medical history is significant for recurrent urinary tract infections and severe myopia, so we have eye problems. Physical exam reveals that her growth is in the 40th percentile only, so we have some growth retardation. She's noted to have corneal calcifications. Laboratory evaluation was remarkable for microscopic hematuria. Creatinine was 1 mg per deciliter, which is a little bit high for a 7-year-old girl. Magnesium was really low, 1.2 mg per deciliter. Serum calcium 9. Fraction excretion of magnesium was very high, 15%. We said normal 3 to 5%, and if someone has hypomagnesemia, it should be below 2%. If it's higher, then you have renal wasting. Urine calcium was elevated at 12 mg per kilogram per 24 hours. Normal should be less than 4. Intact PTH was elevated, like you would expect in patient with hypocalcemia, although here she's not hypocalcemic, but yet PTH is elevated. Why is it elevated? Well, she is hypomagnesemic, right? Renal ultrasound reveals nephrocalcinosis. What's the diagnosis? So here I underlined what you need to make the diagnosis. So you have hypomagnesemia with hypercalciuria. You have nephrocalcinosis. You have renal impairment, okay? Visual problems, like I said, in a child. So I really spelled it out for you. This presentation is consistent with familial hypomagnesemia with hypercalciuria and nephrocalcinosis, FHHNC type 2. Why type 2? Because of ocular abnormalities. This is a rare genetic disorder. It is due to a mutation in the tight junction protein Claudin 19. If we did not have ocular problems, it would have been Claudin 16. Detailed family history is paramount. You want to inquire about consanguineous marriages, consanguineous parents, and that was the case here. This patient exhibited many of the characteristic features of FHHNC type 2. Genetic testing is required, and it did ascertain the diagnosis. Let's conclude with key points. Diagnosis of magnesium metabolic disorders require a high index of suspicion because magnesium is not included in routine chemistry panels. The presentation of both low and high magnesium, kind of the same like other electrolyte disorders, a lot of non-specific symptoms. You can see the same with hyponatremia, hypokalemia, hyperkalemia, hypocalcemia. So you need to order magnesium. Hypomagnesemia is an important cause of both recalcitrant hypokalemia and hypocalcemia. Hypermagnesemia is not as common as hypomagnesemia. You see it mainly in patients with advanced CKD, chronic kidney disease, who are taking exogenous magnesium. Magnesium can very easily be replaced orally or intravenously. Severe hypermagnesemia is a serious electrolyte disorder that requires emergency treatment with intravenous calcium, intravenous fluids, and in rare cases, hemodialysis. So this concludes this chapter on magnesium. Next time we'll discuss calcium. See you then.